name's Cassie. I'm a PA student at the University of Cumberland. Are you Mr. Doe?
Yes.
Okay, just give me a second. Let me wash my hands. Okay, let's check your bracelet and make sure your birthday and MRN are the same, and your name. There's my stuff. Yep, it's the same. Okay, so understand that we're here for an abdominal exam today, correct?
Yes.
Okay, so I'm just going to give you some time to empty your bladder. We're going to make sure that we have good lighting in the room. So I'm going to have you lay supine, so lay down. This is your pillow for your head. And have you place your arms to the side. And we're going to make sure that our stethoscope and our hands are warm just for patient satisfaction so they're not uncomfortable. If we notice that they're getting uncomfortable during the exam, we could try to start some conversation to distract the patient a little. Also, I'm going to make sure I'm standing on the right side of the bed. So I'm going to drape the patient. So we're going to drape the patient from the xiphoid process. A little bit too much. So from the xiphoid process down to the pubic symphysis. Okay, so we're ready for your exam. So we're going to start off with inspection. So first, normally he would have a shirt off, but first we're going to inspect just 4 quadrants. So you have your right upper quadrant, or left upper quadrant, right upper quadrant, left lower quadrant, and right lower quadrant. Then we would inspect the skin. We would look for any scars, striations, any dilated veins, any bruising or rashes present. Then we can look at the contour of the shape of the abdomen. We could see if it is scaphoid, flat, rounded, or protuberant. We would check the symmetry. It should be symmetric. Any asymmetry could be indicative of any masses or visible organs present or tumors that could cause that asymmetry to happen. Then we would look at the umbilicus. So we would just see that any inflammation or hernia is present. And then we would look at the abdominal aorta. Pulsations are normally pretty visible, but mainly we're looking for increased pulsations that could give an idea of a AAA. So after inspection, we are going to move on to auscultation. Normally we would auscultate first, but in this case, percussion and palpation can alter the valve frequency sounds. So we're just going to auscultate. We use a diaphragm and my stethoscope. And we're going to listen to the right lower quadrant and just listen for some vowel sounds. You could listen in all quadrants, but we're just going to listen to one right now. Okay, now we're going to listen for any bruits and 4 main arteries. So we're going to listen at the abdominal artery and then the renal arteries on both sides. And then you can find the belly button, and right below that would be the iliac arteries and then the femoral arteries. Again, just listening for bruits. So we could also listen for friction rubs. You would listen to these at the anterior chest, above the costal margins, on the right and left side. So over the liver, you would be listening for any frictions and rubs, and over the spleen. And if you did hear any friction rubs, that you could indicate a hepatoma, any gonococcal infections, or pancreatic carcinoma. So after auscultation, we are going to percuss. So normally we're just going to percuss in all 4 quadrants. While we're percussing, we're just going to try to determine the distribution and frequency of gas in the area. Tympany is pretty much going to dominate because the abdomen is mainly of gas. And if you did hear any dullness, that could lead us to palpation. So any masses or enlarged organs, when we percuss in these areas, when we start to palpate, we can palpate those areas to see what we feel. So now we're just going to percuss over the left the right side, the anterior chest just above the costal margins. We're going to percuss, and it should be dull because that's where the liver is located. And over here on the right or the left side, again above the costal margins, we're going to try to find the gastric bubble. Right there it is, and it should be tympanic. All right. After percussion, we're going to palpate. So with palpation, we're going to start with a light palpation first. Again, with all four quadrants, going to make sure my fingers are together. We move in a swift motion in a horizontal plane. While palpating, we're feeling for any masses, checking for any tenderness or any muscular resistance. If we did feel any muscular resistance, we need to distinguish that from involuntary guarding or voluntary guarding. So if we did have susceptibility or suspect any masses, you could do a deep palpation, so use both hands and then palpate deep in these areas that you did suspect any masses, just to rule those out. Okay, so since we're finished just with like an initial inspection of the abdomen, we're going to move on to certain organs. So the first organ we're going to look at is the liver. Or not look at, feel for, I guess, the liver. So the liver is located on the right side, and we're going to try to determine its shape by doing a vertical span. So for the vertical span, for the lower border of the liver, we would find the belly button and then come across to the midclavicular line and start to percuss up until we hear dullness. So it's about in this area right here. You could mark this area if you needed to, just for a better measurement, but we'll just keep it in mind that it's right here. So for the upper border of the liver, we're going to try to determine where the nipple is, and then just start palpating down from that. Oh, that was pretty high. So about right here in this area, so about this measurement is where the liver would be at the midclavicular line. It should normally be about 6 to 12 centimeters long. Then you could try to palpate the liver. The liver is sometimes hard to palpate, but in this case we're still going to try. So I'm going to place my left hand under his back where the 11th and 12th ribs are located, and then take my right hand and then press it under the ribs, and I'm going to take in a deep breath and try to feel for the liver edge, the lower border of the liver edge. But I can't feel it, but it could extend 3 centimeters at that midclavicular line below the costal margin. So in this case, when you can't feel the liver and you still need to check for tenderness, so for a non-palpable liver, we can place our right hand over the right rib, or left hand over the right rib cage, and then do a fish strike. And if he had any tenderness, he would tell me. And we also need to compare it to this side, just to make sure that it's the liver that's actually tender and not the whole abdomen. Okay. So after that, we are going to move on to the spleen. So just to keep in mind, before percussing the spleen, if you're trying to percuss the stomach or like in the colon area and you do feel any dullness, you need to keep in the back of your mind it could be splenic enlargement, because when the spleen enlarges, it enlarges anteriorly, down, and then more medially. So when you're percussing these areas in the area of the stomach and colon, it could be dull, so just keep that in mind, that it could be splenic enlargement. So you can test splenic enlargement 2 ways. You can use trial of space, so it's kind of like an imaginary triangle in your mind. So you can find the 6th rib, so we'll walk down to the 6th rib, and then we'll check, I'll move this up a little bit. We're going to check for cardiac dullness, so it's about right here. From here, we're going to palpate down into the anterior axillary line. So after that, we're going to palpate to the lower margins of the costebral margins, and then we can palpate back up. And this should all be tympanic. If you hear any dullness, it could be a result of an enlarged spleen. So you could also palpate or percuss down the lower anterior axillary line, and then you can have the patient take in a deep breath. While he's taking in a deep breath, it should be tympanic the whole time. If it changes to dullness, again, it could be splenic enlargement. So now we're going to try to percuss the spleen. It's the same way we tried to percuss the liver, except this time I'm going to place my hand again under his back. Place my right hand deep under that costal margin and the right upper quadrant. Ask him to take in a deep breath and to try to feel for the spleen. Okay. So after the spleen, we're going to move on to the kidneys. The kidneys are retroperitoneal, so they're probably not going to be palpable, but we always still want to try. So kidneys are located on both sides. So for the left kidney, I'm going to move on over to this side first. So palpating the left kidney, I'm going to put my right hand, my fingertips, I'm going to find his costal vertebral angle, or the CVA, and then take my left hand and then try to push it up under that costal margin. And then I'm going to press in with this hand, so anterior with my left hand and down with this hand to try to squeeze in that kidney, but I can't feel it because it's retroperitoneal. Okay. So we're moving to the right side now to do the same thing, except this time I'm going to use the left hand to press under his back with my fingertips at the CVA, and then my right hand right under that costal margin, and then pressing up with my left hand and down with this hand to try to feel for that kidney. Okay, so since we can't feel for the kidney, we still need to check for tenderness. So I'm just going to have you raise up. We're going to check for we're just going to do another fist strike. So we're going to find the costal vertebral angle again. Somewhere here it is. Okay. So here we're going to put the ball of our hand right here and do a fist strike, and he would tell me if he had any tenderness, and we would do the same for this side. Okay. So if he did, you can lay back down. If he did have any tenderness, it could be indicative of polynephritis or kidney infection, or any musculoskeletal causes. So after the kidney, we're going to move down to the bladder. When you palpate the bladder, you're going to palpate above the pubic symphysis. So palpating the bladder should feel, if it's distended, you should feel a smooth, rounded area. And then we can percuss the bladder. And in order to feel a correct percussion of the bladder needs to be 400 to 600 milliliters filled of fluid, so we can determine that shape with percussion. So again, above the pubic symphysis, and we would just palpate to feel for that. So after the bladder, we are going to move on to the abdominal aorta. So the abdominal aorta is shifted a little bit to the left of the midline of the abdomen. So we're going to move over to the left a little bit, and then I'm going to take both hands and kind of squeeze it together and feel for that abdominal aorta, and it shouldn't be more than 3 centimeters. Okay. So after that, we're just going to check for a few random things. If the patient came in and they had a swollen bladder, that could be indicative of ascites, so just the abdomen filled with fluid. You can, normally while percussing, it would be dull in this area and more tympanic here in this area. So while percussing, you can have the patient roll to the side to see if there's a shift in dullness. So if he rolled to this left side and I percuss over here, while he's on that side, I can percuss here and it should be tympanic up here and dull down here. So, and then vice versa, when he rolled to this side, it would be dull and then tympanic on this side. That just means the fluid is shifting to each side. Also, I can have him or somebody, a nurse or somebody, help and hold down this area. So we're just blocking off where the fluid would go, and we're going to hit one flank and see if we can see a reflection, I guess, on the other side. That means that there's the fluid wave of the ascites when you hit one side to the other. And then you can check it both ways, I guess. So after that, we are going to check for appendicitis. So the patient was coming in with some pain in that right lower quadrant. We can do a few tests to run to see if there's positive signs of appendicitis. So the first sign would just be rebound tenderness. So I would just press this in really hard, and when I let go, it would be tender or increased pain after that. Then you can do Rosving sign. So appendix is located down in this area, but we could press in the left lower quadrant, and if he felt pain in this area, that would be a positive Rosving sign. So with another test you could do is psoas sign. So again, he's laying straight, and I could press my hand over his knee and ask him to try to lift his leg up. And if he had pain with that resistance of lifting his leg in this area, that would be a positive psoas sign. And then the obturator signs, I'm going to move this for just a second. Obturator sign, I'm going to have this bend his knee up, and then I'm going to rotate it internally. And if he had any pain in this area during that rotation, that would be pain in the hypogastric region. That could indicate appendicitis. Okay, so after appendicitis, we can check for cholecystitis. And this is called Murphy's sign. So I'm going to put my fingers right under the border of that right costal margin. I'm going to press in and ask him to take a deep breath. And any stopping in breathing or increased pain while he's taking a deep breath is a positive Murphy sign for cholecystitis. So after that, we can check for any hernia. So if the patient comes in and thinks that they have a hernia, well, first of all, a ventral hernia is located in the abdominal area, so it excludes it from an inguinal hernia, which is in the pubic area. So we can have him lift his head up and his shoulders, and we would watch for a bulge in the abdomen for the ventral hernia. So then after the hernia, we can check for if we suspected any masses to determine if it's intra-abdominal or just an abdominal mass. We can have the patient kind of squeeze his abdominal muscle, kind of like he's doing a sit-up. And in those areas that we suspected a mass, we could palpate. And while he's squeezing his muscles, so with muscular resistance, an intra-abdominal mass is not going to be present, but an abdominal mass would be. So intra-abdominal mass excludes muscular resistance, so you won't feel an intra-abdominal mass while he's lifting his body up. Okay, so I'm just going to have you sit up now. So that's going to exclude our exam today. We'll get all these findings together and I'll show them to my supervising physician, and we'll come back and talk to you in a minute, okay? All right, have a nice day.